Good evening, everyone. Good evening, everyone. I will ask you to wait more 10 minutes. 7:15, we are going to start our broadcast with Dr. Alexandre Moreira. Soon we are going to be back.
Boa tarde, boa noite, boa tarde. Lívia, podemos começar.
Good evening, everyone. I'm Lívia Uehara. I'm a physician and the current vice president of the Spiritist Medical Association, that I will refer as a SMA. On behalf of the SMA, I welcome all of you to the webinar series, Spirituality in Mental Health. And tonight we are excited to have Dr. Alexandre MOREIRA-ALMEIDA presenting on guidelines for integrating spirituality into the prevention and treatment of alcohol and other substance use disorders. Before introducing Dr. Alexandre MOREIRA-ALMEIDA, let me introduce my co-host, Dr. Paulo Bispo. Paulo is a PhD, assistant professor at Harvard University and member of the SMA. Our program will start with a brief introduction for those who are not familiar with the Spiritism and with the SMA. Then I will say a short prayer and Paulo will introduce Dr. Alexandre MOREIRA. Spiritism is a science supported by empirical evidence and is a philosophy based on the moral teachings of Jesus. The main tenets of Spiritism include the existence of supreme intelligence, immortality of the soul, reincarnation, mediumship, and plurality of inhabited worlds. It is important to note that Spiritism is open to all beliefs and religions and has no discrimination whatsoever, including race, gender, ethnicity, or culture. SMA is a non-profit organization directed by Spiritist medical doctors. Our main purpose is to improve clinical treatment outcome by teaching about the influence of spirit and soul in physical and mental health. Our vision is to advance spiritual care in routine and clinical practice. Our mission, to educate healthcare professionals and support research on the impact of the spirit and soul in physical and mental health. The SMA USA works by organizing conferences, webinars, and publishing articles. You can support our cause by becoming a member. We have 3 membership categories: healthcare professionals, students, and non-healthcare professionals. In summary, anyone can become a member. And the link for the membership is going to be posted in the chat box. Members are entitled to discount fee in webinar registration, and they are going to have free access to the new activity called Spirituality and Science in Discussion, in which a panel will discuss scientific publications of interest. The audience will have a chance to interact with the panelists in Zoom. Now I will invite you for a short prayer, and afterwards, Paulo is gonna introduce Dr. Alexandre MOREIRA. If you feel comfortable, you can close your eyes, or you can keep your eyes open. It's just to internal connection with yourself. I invite you to pay attention in your breath, in your thoughts. Take a deep breath. Let's elevate our thoughts to a higher power. And let's to connect all of us in that interaction tonight. To have our intelligence, our brain, our conscious, all connected together to learn and to bring better for us and for the patients that we assist in every day. So be it. Paul is with you.
So be it. Thanks. Great. Can you hear me well?
Yes, perfectly.
Perfect. Great. Well, it's always a pleasure to be here with you and a pleasure to introduce our speaker as well, Dr. Alexandre MOREIRA-ALMEIDA. Dr. Almeida is an MD, PhD, professor of psychiatry and director of the Research Center in Spirituality and Health in the School of Medicine at the Federal University of Juiz de Fora in Brazil. He's the current chair of the section on spirituality of the Latin America Psychiatric Association, a a former chair of the sections on religion, spirituality, and psychiatry of the World Psychiatric Association and the Brazilian Psychiatric Association. He's authored more than 170 papers published in peer-reviewed journals and also chapters, and those papers and chapters have received more than 7,000 citations. So just a quick reminder to everyone who's joining us online. After the talk, we're going to have about 30 minutes for discussion. So please, for all of you joining us tonight, enter any comments, questions in the chat box available in the app. I'll be monitoring all of those questions during the talk. I'll be glad to share them with Dr. Almeida later during the Q&A session. So thanks again, Dr. Almeida, for being here with us today. The floor is yours.
Hi, thank you very much. It's a great pleasure being here to discuss and present the guidelines about how can we integrate religion and spirituality in the prevention and the treatment of substance use disorders. So let's start the presentation. Okay. So this, I will present an overview of the guidelines for integrating spirituality in the prevention and treatment of alcohol and other substance use disorders. This guidelines has just been published at the Brazilian Journal of Psychiatry. It was based on the available evidence, scientific evidence on the impact of spirituality on substance use and abuse. And these guidelines, they were reviewed and endorsed by many of the key leaders in the study of psychiatry and spirituality, and also of substance use disorders in Brazil and abroad. In the end of our presentation, we will present a list of endorsements of this presentation. And this paper, it has just been published. It's available for free access online on the Brazilian Journal of Psychiatry. Okay, so let's start. First, to discuss definitions, we know that there is a large there has been a large discussion on what are the exact definitions of spirituality and of religion. Despite all the controversies, several key authors, and we are in line of these authors, we defend the idea that spirituality is the relationship or contact with a transcendent realm of reality that is considered sacred, the ultimate truth or reality. If we see basically all spiritual traditions throughout history and throughout the globe accept some sort of transcendental reality. We can call it God, gods, spirits, ancestors, angels, whatever. But basically all spiritual traditions talk about some sort of transcendental spiritual realm. And this spiritual realm is considered to be sacred, the ultimate reality, the utmost importance. Okay, and religion would be the institutional or communal aspect of spirituality, a shared set of beliefs, experience, and practices related to the transcendent and the sacred. Of course, a person can be spiritual but not religious. However, throughout the globe, most of the people experience their spirituality in a religious context. Just to give an idea, the most recent global data on religious affiliation, this is a survey provided by the Pew Research Center. Basically, 84% of the global population reports a religious affiliation. So, by large, most of the world's population has some kind of religious involvement, 84%. And among the 16% that does not have religious affiliation, but many, probably most of them, has some sort of spirituality. The contacts with the ancestors, they believe in God and things like that. Okay, these definitions are we used in our recent book, Spirituality and Mental Health Across Cultures. This is a book that we edited with Professor Dinesh Bugra, former president of the World Psychiatric Association, and a Brazilian colleague, the psychiatrist and chair of the section in spirituality of the Brazilian Psychiatric Association, Bruno Paz Mosqueiro. This book was published by Oxford University Press last year, and it is a collection. It's an edited book. We have more than 30 authors from more than 12 countries analyzing how can we integrate spirituality into clinical practice in an ethical way and in an evidence-based way. So this is basically the idea. And based on the review of the literature, we provided these definitions. And they are very important to us in discussing regarding substance use and abuse, because the spirituality, the idea of connection with the transcendent would be very important to many patients with substance use disorders. And also the communal aspect of religion will also quite often be a key element in the recovery of many patients. Okay, and just to provide in the beginning a brief summary about the evidence, the current evidence of the impact of religion and spirituality on health and on mental health. We have nowadays a very robust evidence that higher levels of religious and spiritual involvement. Usually, these studies investigate religious and spiritual involvement in different ways. The most used are frequent attendance to religious services. For example, people who attend more or less than once a week at religious services. Or intrinsic religiosity, how committed is the person to live in his or her life their religious beliefs and ethics and things like that. And also religious coping, positive and negative spiritual and religious coping. We have nowadays literally thousands of empirical studies investigating the impact of these different ways of religious and spiritual involvement and health, especially mental health. For each of these items that I will describe now, there are more than 100 studies for each of these outcomes that we are discussing here. On average, religious involvement, especially weekly attendance to religious service, is consistently related to lower general mortality, a decrease between 30 to 50% in general mortality among those who attend at least weekly a religious service. There are also usually a correlation with lower levels of depression or faster recovery from even severe depressive episodes. Lower levels of suicidal behavior, including suicidal ideation, suicidal attempts, and suicidal deaths. For example, just to give an idea, the largest and the best study so far on this was led by Professor Tyler van der Wielen, full professor of public health at Harvard University. They followed up about 80,000 people for 14 years. People who attended a religious service at least once a week died 6 times less from suicide during this 14 years follow-up. And this, even after controlling for attendance and for, not for attendance, even after controlling for sociodemographic and other clinical variables. Also, as we'll discuss here, one of the most consistent finding is exactly regarding substance use and abuse. We know that usually higher levels of religious or spiritual involvement is related to lower levels of use of alcohol and other substance, and also lower levels of abuse and dependence. This has been one of the most consistent findings in this research area. And also regarding positive outcomes in positive health, positive psychiatry, and positive psychology, we have also a consistent correlation between spiritual religious involvement and better quality of life, human well-being, and human flourishing. Of course, there are also negative impacts, especially negative religious coping, when people, for example, assume a very passive coping strategy, a deferral to God to solve all problems, or conflicts about treatment. For example, specifically in terms of substance use and substance dependence, is quite common sometimes that some religious groups, for example, advise against seeking medical treatment and medical help, focus only on spiritual approach, as if they were incompatible with each other. Okay? So based on this, several medical and other health associations have recommended the use or the integration of spirituality in research, in teaching, and in clinical care. For example, the World Psychiatric Association published the position statement on spirituality and religion in psychiatry. We were part of the working group that developed this position statement that was approved by the World Psychiatric Association. And this position statement was published at the journal World Psychiatry, and it's freely available online on the website here in the bottom of the screen. And this position statement has been translated to 7 different languages. All of them are available free of charge on this website. It describes the importance of integrating religion and spirituality in psychiatric training, in psychiatry research, and also in psychiatric clinical care. This is just an example, because religion and spirituality is a part of the position statement, that religion and spirituality is relevant to the oranges. Understanding and treatment of psychiatric disorders involves patients' attitude. It should be central to clinical and academic psychiatry. So it's important. So one of the first recommendations of this position statement is that religious and spiritual beliefs and practices should routinely be considered when taking the patient's history. So taking spiritual history is one major step, and we'll discuss this soon in this guideline. So those who are interested in knowing more about this position statement in these 7 different languages available in Chinese, in Arabic, in French, in Dutch, Spanish, Portuguese, and English. Okay? And so the main reasons for integrating religion, spirituality, and mental health is, first, as we had described previously, most of the world's population has some religion and spirituality. Is an usual coping strategy, religion and spiritual coping. It impacts health, as we have showed previously. Addressing religion and spirituality impacts prognosis. There are randomized controlled clinical trials showing that. Most patients want that clinicians, most or at least a substantial proportion of patients want clinicians to address their religion and spirituality, and is a component of an integral patient's assessment. Of course, we're not saying to neglect the biological, the psychological, or the social aspects of the patient or of the disease. But we are calling to integrate all these aspects to the spiritual aspects, to a truly biopsycho social spiritual approach. And it has been recommended by many medical and health organizations, as we had discussed previously. Specifically regarding substance use and abuse, recently, I think it was last year, the International Society of Addiction Medicine has published also a position statement, a guideline about the integration of spirituality in substance use. And also in Brazil, in the state of Minas Gerais, spirituality was included to a plan to prevention and treatment. We were part of this, and the current position statement, current guideline is a development of this initial guidelines that we have developed for the state of Minas Gerais in Brazil. So, again, emphasizing the biopsychosocial spiritual approach, specifically regarding substance use disorders. For example, patients and the substance use disorder has a biological aspect. That is, for example, genetic predispositions, innate tolerance to some level of the substance in the body, psychological aspects like impulsivity, novelty seeking, the personality traits, low self-esteem. All these can be related to higher risk to have substance use disorders. Social aspects, for example, living in an environment where substance use is very common, or, for example, a traumatic experience in childhood, abusive experiences, all of these social aspects are relevant to substance use disorders. And specifically also regarding the spiritual aspects of this, for example, the loss of existential meaning. This is the idea of the connection with the meaning life, the connection with the transcendent, the loss of this existential meaning. Regarding oneself as sinner or being banished by God, for example, are two very common experiences of people suffering from substance use disorders. So let's discuss the main guidelines for ethical and evidence-based incorporation of religion and spirituality in the prevention and treatment of substance use and misuse. The first is taking a spiritual history, collecting the patient's spiritual history. This has been the most agreed intervention to integrate spirituality in clinical practice in all settings. It has been the most studied intervention, and it has showed many positive impacts. Okay, first, when we ask a patient about their religion and spirituality, and the questions could be as simple as, do you have a faith, a religion, or a spirituality? The second, if the patient says yes, okay, tell me more about this, or tell me more about your religious spiritual involvement. Are you related to any specific religion or spiritual community? How important is this community, this participation, these beliefs, or this practice important to you? And specifically, how important do you think it could be to your recovery? Which kind of spiritual practices and beliefs have been useful for you in the past, and how of this do you think could be useful nowadays to you to deal with the current problem? So these are the main questions for a good initial spiritual history. So collecting the patient's spiritual history can help to identify the patient's religious and spiritual resources. For example, practices and beliefs that the patient holds and the groups in which she or he participates. And this may be helpful in the prevention or in treatment. So, for example, the when the patient is living or integrated in a social environment that does not involve substance. So socialization without substance. This is, for example, a major problem with adolescents at risk or with patients. We know, for example, that some patients, they most patients with substance or addictions of dependence, they usually have a very restrict social circle, and basically all the people in their social circle are also related to substance use and abuse. So it's very difficult for them to withdraw from this social environment, and they feel quite often very alone. So if in the religious community they can help, they can find a good social network in which it's possible to socialize without the use of substance, it could be very helpful. So this is so the first step is taking patient spiritual history. Okay, let's move forward. The second point is exactly based on this spiritual history, in which we identify the potential religion and spiritual resource of the patient. We could encourage the use of positive religion and spiritual resources that the patient have in their treatment, or even if we are talking about prevention, people in general can have. Just to give also a very important aspect is all this approach must be patient-centered. That means that we should never impose our own beliefs, religious, spiritual, or anti-religious or anti-spiritual beliefs. We must focus on what is important to the patient. So we are not talking about preaching to the patient. We are talking about raising or asking the patient which are their religious resources, and try the patient to think about the possibility of these spiritual resources can be useful in their own treatment. The same way that we perform, for example, regular medical history. For example, we ask about the social environment, we ask about the hobbies, we ask about positive aspects. For example, the patient have friends or relatives or a hobby or something very meaningful to them, or physical activity, and we stimulate patients to get involved with these positive aspects of life that can help them to overcome the dependence. We exactly the same way we perform in terms of religion and spirituality. So we identify, for example, some examples of possible positive religious resource that the patient will have that can be useful. And these resources have been investigated in several studies. And actually, there are many randomized clinical trials of CBT, cognitive behavioral therapy, integrated to religion and spirituality. And this integrated CBT have been submitted to randomized clinical trials and proved to be at least as effective as regular CBT. And which are the main spiritual and religious strategies that are incorporated in these CBTs? And these strategies are quite often used by patients, and they think as very useful. So some examples. First is attending religious and spiritual services. When the patient go weekly, for example, to a religious group, a religious service, first, it's a kind of behavioral activation. The patient start to have new activities. It goes beyond to be so inactive. That's quite often in depression and things like so. It's parts of behavior activation. Second, it also helps the patient to create new social bonds. So it increases the social network. Also, in this environment, the patient can also work, for example, voluntary work, and voluntary work can be a good way also of social integration. Also, the patient can have access to role models, people who faced and were able to cope successfully with stressful situations, and this can be helpful to them also. Another positive religious research or spiritual research, for example, the habit of having prayers or meditation on other religious practices. For example, the patient could tell, oh, I used to every morning in the past to read 20 minutes of a religious spiritual text and then pray and meditate on it to start better a new day, to seek for inspiration, to strength and wisdom to cope with the challenges of every day, for example. So, I think I could resume this practice. So this is one example. Other possibility also is to be able to talk to someone in their community about their own problem and to seek some advice to overcome it. Also, the perception of the purpose of life. Usually, religious and spiritual traditions talk a lot about the meaning of life, the meaning of the each person, and the possibility of having a more positive view of the person himself and of life. And for example, in also very important, as I said previously, is very common in the course of severe dependence, people get involved in many negative acts, in violence, in crimes, and many people are very guilty about all these things, and quite often they feel very bad about themselves. They feel themselves as sinners, as abandoned by God, and someone that is completely hopeless. And and quite often religions provide some ways of tuning to of overcoming these negative feelings and the feeling of forgiveness from God, forgiveness to himself and for other people. So all these possibilities are possible strategies that can be useful for patients. Okay, so let's move to the next slide. The third item. Oh, this is exactly what I had talked previously, taking spiritual history and collaborative approach, exploring potential useful spiritual research. I said about religious, reading religious spiritual texts, cognitive framework also. The idea, for example, that life has a meaning, that if I'm facing a stressful situation, I have the resources to cope with it. For example, if God is good, if God is just, if something is happening to me, there is a reason, that is usually a positive reason, that is a lesson to be learned, and also that God would never make me to face or to cope with a situation that is beyond my strengths. So if I'm facing something, I can handle it in some way. I can seek help, and this help can be, for example, in the community, the religious community, could be through prayer. And another very positive religious framework is, for example, that instead of thinking that I'm omnipotent, that have the control of everything in my life, this is one extreme. There is the other extreme, negative extreme also, is that I have no control in my life. God or my karma of past life or God or obsessing spirits are causing all of my problems and I can do nothing. So a very intermediary strategy is a collaborative coping with God, in the sense that I do whatever I can, I do the best I can to solve the problem, and the rest I trust in God. So I cannot do everything by myself, but I cannot defer everything to God, to spirits, or whatever. So this kind of partnership with God or with the spiritual entities could be very useful. So listening to or watching religion and spiritual programs, okay, and community service, attending religious services, as we had discussed previously. Okay, so for those who also like to go further in these strategies, and especially the cognitive behavioral therapy that is adapted to religion and spiritual aspects, we just published, this is an open access journal, we just published a paper that summarizes the main cognitive behavioral techniques of integration of religion and spirituality to CBT. And these were exactly the techniques that have been proven to be effective in randomized clinical trials. So it's exactly what we have discussed previously. Here is more details about the coping strategies, as we said previously, the coping strategies. Use private religious activities like praying, reading religious texts, meditations, and all this stuff. Okay. And then the biopsychosocial spirit approach, using approach from all these dimensions. This is very, very important. We need to remember or to remind physicians, for example, that cannot pay attention only in the biological aspects. We need to remind psychologists that we cannot pay attention only to psychological aspects, or to the religious groups, that we cannot pay attention only to religious spiritual aspects. But we need and must integrate everything in the best interest of the patient. So for example, some examples of this integration. Biological aspects, we can, when required, using medication, for example, to treat depression or to treat alcohol withdrawal symptoms and things like that. A healthy diet, practicing physical activity. All of these are interventions in biological aspect of individual. Psychological interventions, psychotherapy, psychoeducation. Social interventions, encouragement of improving and increasing the relationship with family, with other social contacts, health leisure activities. So these are some examples of social interventions. And the spiritual intervention, supporting the use of positive religious spiritual resources that the patient may possess. So the patient and the professionals do not need to choose between these interventions. It will be much more interesting if we sum this intervention. They can integrate and potentialize each other. So this is very important. In addition, the fourth part of the guideline is to strengthen a partnership with religious and spiritual-based community resources. For example, AA and NA. We know that AA and NA are based on the 12 steps. And 6 of the 12 steps are related to spirituality. One of the key concepts of the 12 steps and of AA is the spiritual awakening. The idea that the person has a spiritual awakening, and this is very important in their recovery. And we know the importance of AA and NA in public health. That is a study that it was published a few years ago with a nationally representative sample from the United States, showing that most patients that recovering from some sort of substance problems, the people who recovered from, about 90% of the general population in the US has had in the past some sort of problems with substance use, but they do not have anymore. Okay, 90%. These people, from those who seek some help, because many people recovered by themselves, although we know is much less effective recovering by himself, it happens. But from those who seek some help, most people seek the help from self-help groups like AA and NA. So there is a huge public health impact, AA and NA, and they are strongly based on, they are not religious groups, but they are strongly focused on spiritual aspects also. So sobriety pastoral care services in Catholic Church, support groups, so they are part of a comprehensive approach to treatment. So we can perform our medical psychiatric treatment integrated with psychology, social work, religious community, and also this spiritual-based community research like AANEA. So we may refer patients to them, and also we may receive patients referred from these groups. Exactly, what we are proposing in more details in the fifth aspect of the guideline, a two-way partnership with religious and spiritual communities. For example, the religious and spiritual communities can identify patients with substance use problems and refer them to health services and treatment. We know that many people first seek help from religious community when they are facing some mental health issues or specifically problems with substance use. So if the religious leader sees that the patient has some problems with substance use, they can refer the patients to the health services. On the other side, we can welcome and support patients. In the opposite. The religious communities, they can also welcome and support patients being treated in the health services. We can also, from the religious services, from the health services, we can refer patients to their religious communities to have support. So we can have this two-way partnership. And also, it's very important to have some sort of spiritual assistance in patients treated in community and in hospitals. So to provide access, for example, to chaplains, to spiritual assistance to inpatients, for example, would be very important. In addition, we could discuss about the inclusion of patients' religious and spiritual content in the treatment and recovery programs for substance use disorders. For example, as we said previously, it would be important to include in the public health programs and in preventive programs and so on and so forth, to pay attention to religion and spiritual aspect of the patient and of the resources in society. Okay, and these guidelines, they were endorsed by different associations from different psychiatric, the Brazilian Psychiatric Association, and also representatives from the three main religious traditions in Brazil, from the Catholics, Catholics at the sobriety pastoral from the Catholic Church, the Spiritists, the Brazilian Spiritist Medical Association, and also the Protestant and Evangelicals, the Brazilian Association of Christian Science and the Brazilian Evangelical Christian Alliance. All of them endorsed this, so the idea is exactly to promote these guidelines to religious communities and also to health services. And the endorsement, we got endorsements and also some inputs from leaders in Brazil and abroad, since the president of the Brazilian Psychiatric Association, the vice chair of, and currently the chair of the section in spirituality from the World Psychiatric Association. So we had also the support of many different authors. For example, in the United States, Mark Galanter, one of the key authors in spirituality, Ken Pargament in psychology of religion, John Petit, professor of psychiatry from Harvard, Harold Koenig, the key leader in medicine and psychiatry, Professor Chris Cook from the Royal College of Psychiatry in UK. So this also in many other authors from Brazil. So this is the idea. So it's open. As I said previously, this paper is open. We are open to all sorts of discussions now. And in summary, the idea is that in respect to the evidence available and in respect to the religious and spiritual beliefs, behaviors, and values of most of the world's population, is not only appropriate, but a scientific and ethical responsibility to integrate religion and spirituality in clinical care and public health. So basically, I think this is something very important to need to keep in mind. For those who'd like to know more about religion and spirituality, we have a YouTube channel from our research group. It's called TV Noops. It's bilingual. Most of the content is in Portuguese and in English. We have more than 300 videos from many of the key authors in science and spirituality and health throughout the globe. So for those who'd like to have more details in each of the things that we discussed here, this is also a possibility. Here are also my contacts, my email. So I would be very glad to take questions from the audience. Thank you very much.
Let me unmute myself. Can you hear me now? Yes. All right, cool. All right, well, thanks again. That was a very interesting talk, Alexander, and thanks for sharing all of your experience as a clinician and also as an innovator in the field, because we know these tools, are sort of new in clinical medicine, and you're with your group and many others developing tools to integrate spirituality in the treatment of mental disorders, including substance abuse, as you shared with us today. So we usually tend to give much more attention to clinical pharmacological interventions, right, while completely neglecting sometimes other important dimensions of human beings, of our patients. And this work is very exciting, I think, and the work that you're doing and of others showing, that there is good evidence for changing the way that we look at patients to treat all the different aspects and dimensions of one existence, including spirituality and religion. So thanks again. So I think we have a couple of different questions here in the chat. A lot of them are, very similar. So I'm going to try to combine a couple of these questions here so we can have a little bit of a discussion. And if you are watching us from YouTube or any other channel, please, you can send your question through the app, and I'm going to do my best here to translate these questions to Alexander and include these questions in the discussion as well. So regarding the first question in your guideline or the questionnaire about collecting the patient's spiritual history. So you collect the history of religion or spiritual views for the patients, and which kind of practice that they have used in the past positively to help them cope with a lot of mental struggles and to help in the treatment of mental disorders. So I think one of the common questions that we have here is that how to adapt the remaining parts of the questionnaire, or how to adapt your whole approach when in the first question you identify that the patient is not affiliated to any religion, or the patient is agnostic or atheist.
Okay, very important question. As we said previously, the approach must be patient-centered. It's not a matter of preaching to the patient, to any religion and spirituality, but to explore the patient's spirituality. So, for example, first, if we ask the patient has some religion and spirituality, and the patient says that he or she does not have any, it's okay, of course, and we can ask them, for example, what is meaningful to you? What does meaning to your life? What matters the most to you? So the idea is to grasp the values of the patients, the core aspects of patient's existence. So then we can explore these aspects. For example, the patient can say my family, or nature, or arts, or politics, whatever. So we can explore this. So this is one way to approach it. The second point is to ask, if the patient says, no, I'm not, you can ask for them, have you ever been in the past involved with religious and spiritual activities? What happened? So sometimes people had some negative experiences with religious communities, for example, or with a specific religious person, and then because of that, the patient
becomes resistant, right?
Quit from any sort of religious or spiritual participation. And we can explore this, and sometimes just by discussing this, the patient may say, for example, oh, actually it was very important to my life, and perhaps I'm missing something for living this part of my life because of such and such person or such and such experience. So it can be useful, for example, to patient to explore these things, and because perhaps they may be neglecting a very powerful tool for their recovery because of some specific point. So I think these are the two. The most usual is, okay, if you are not interested in religion and spirituality, and what's important to you. But another aspect is very useful also, at least in my clinical practice, when I ask the patient, are you particularly involved with some spiritual issues? The traditional patient says no, but I think it may be useful to me, or maybe I've been wondering about the importance of this, and then we can discuss the patient, help the patient, for example, to explore some possibilities in their lives. But the most important, again, is patient-centered, never imposing, never prescribing religious spiritual practices to
That's right. I think that's the way to go for sure. And I saw that in the guidelines. I have your paper here with me. A lot of these tools, they're actually, agnostic to the religion, let's say, because they're, practices that we know that are relevant to our mental health, well-being, that has nothing to do with the religion. Although some spiritual practices involved that, like meditation, for example, but meditation can be done by anyone, regardless of religion, or if you believe in spirituality or not. And there's a lot of different methods, right? There's compassion meditation, mindfulness, those more associated with the Asian traditions and Buddhism. Anyway, I think there's a bunch of different flavors in those things, and tools that can be used, as you said, regardless of religion and spirituality. And those are very practical tools that can help patients and live better lives and cope better with their struggles. So I think a follow-up question to this is, okay, you shared a lot of insight on how to approach that among a group of patients with no religion or agnostic, for example. And I was thinking about, in Brazil and US, if we think about the population of religious patients now, in Brazil and US, there is a lot of different religions, right? Even among Christians, there are a lot of different affiliations, and the practices are so different. So I was curious to know, in your practice and experience, how different feels and especially conflicting views sometimes of some of these different religions may impact your approach? And how do you fine-tune the approach to accommodate the needs of patients from different affiliations? You mentioned negative coping, for example, and negative previous experiences. And I guess that, in different affiliations and the different religions, some of these views can sometimes be conflicting and sometimes be detrimental actually to the treatment, right? So I was curious to know how, I know that in Brazil, a lot of your patients are probably Christians. We do have a lot of religions that are that has an African matrix, and here in the U.S., most of the physicians here and healthcare practitioners are going to deal with a lot of different religions as well, from Asian traditions and Middle Eastern as well. So I was curious to know, how do you approach those differences in patients from different affiliations, and especially how to deal with the more conflicting and negative views of some of the.
Okay. First, it's useful to have some knowledge about the most prevalent religions in our community, because it's a way to understand a bit more about the background of our patients. For example, in that book that we present in the beginning of our talk, the Spirituality Mental Health Across Cultures, we have a specific section with each chapter deals with the key aspects that we need to know about the main religions, like Christianity, Muslim, Buddhism, and Hinduism, all these major traditions. What are the key concepts that we could know that could be useful for us in clinical practice? So know a bit about this is important. And also, a very useful way is to ask the patient, please tell me, please educate me how your religion deals with such and such problem. So it's a very good way to show the patient that we are open to their religious or cultural background and we are respectful. It's very important to have a genuine interest by the patient's well-being, and also genuine interest in trying to understand better the patient's worldview, for example. So we can ask the patient, so how your religion deals with such and such a thing. So how are the most common practices that you have, and things like that. So this is definitely a way for us to get used to some of this stuff and to discuss of this. But it's also very important to keep in mind that we need to avoid also to stereotypize patients. For example, if patient is evangelical, he's such and such patient. If the patient is Buddhist or whatever. No, we know that people are much more complex than this. But even in the same religious tradition, we have many nuances, many different approaches inside the same religious tradition. But even the participants of each religious tradition, they can mix different concepts, different ideas, or have a very peculiar way to understand this. And specifically, for example, depressive patients. Depressive patients, they have a more depressive worldview, or a very depressive lens through it, by which they see their life or their own religious tradition. So a depressive patient may emphasize very much on the negative and the punitive aspect of some religion, but not necessarily the religion emphasize that very much. But the patient, because he's depressive, he can have this approach. So we need to be careful on this. And specifically regarding the negative aspects of religion and spirituality, first, we must be very careful when we say that some practice is negative, because sometimes we may say that's negative because it's against our conception of life. It is because it's different from our perception. It's bad. If it's similar, it's good. Of course, we cannot do this. We need to have a very culturally competent approach to be sensitive to this. The first point is this. The second point, also we must be careful if the religious leader is actually providing such a negative message, or if the patient is understanding in a negative perspective, or it's distorting the teaching. Sometimes it happens. For example, the patient says, oh, God will never forgive me in such and such situation. And then you can say, have you discussed this with your religious leader? No, I'm afraid of that. Okay, what about trying to talk to the leader? And then after talking to the leader, the patient has a very different perspective to this. So one way is to help the patient, or stimulate the patient to seek some better understanding of their own religious tradition, talking to the leaders or reading religious texts and so on and so forth. Another possibility, but if the leader is actually, for example, saying to the patient that you should quit medical treatment because God will save you and things like that. One strategy that I used sometimes, I ask the patient permission to contact the leader. I said, okay, may I contact your pastor or whatever, your priest? And the patient allows it. And then I made a phone call to these leaders, and I start, of course, not in a confrontational way, but say, oh, I have a patient that's part of your religious community. This is very important to the patient. I'd like to thank you very much for the support, and I'd like to work with you in helping this patient, and so on and so forth. So this patient is bipolar, has a bipolar disorder. It's important to use lithium. It will help to stabilize the patient. In addition to go into your church or whatever, to your groups. What about if we work together? I never had a negative experience doing this. So if we do this a non-confrontational way, let's say collaboration, so it's usually very helpful. But if nothing of this works, we can also talk to the patient. So have you, for example, thought about discussing with other religious groups or other religious leaders from your own religious community? Perhaps there are other people with different perspectives, with different ideas, or of course the patient may have some religious struggle with his or her own spiritual religious tradition, and of course the patient can also seek from different other different religious and spiritual communities that can be useful to them.
Seems to be a very sensitive territory to navigate. And I really enjoyed. I really like the approach that you're using there. It seems to be very diplomatic, and that's one of the questions that we had here. Actually, is how your practical recommendation to better establish these two-way collaboration that you mentioned before. And I think you already touched a lot on these. It has to be very diplomatic, like these, non-confrontational. Um, uh, and make sure that you're not there to teach the gospel or specific views of spirituality, or that you want to increase your flock of one particular religion or something like that. It has to be non-dogmatic, as you said, non-confrontational, and very diplomatic. Um, let's see. I think we have a couple of more questions here. Do we have more time? I'm kind of lost here on time. Do we have more time? If you have to leave, let me know, because we have a couple more questions here, and I'm going to go through, try to go through a couple of them. When you're talking about some of the experiences that you had there, and these experiences that you have is so rich and helpful, especially on the practical way, right? Because a lot of people here are trying to better understand how to do that with their patients, but also how to lead with the communities, with the churches, and so on. I was thinking a lot about, especially those patients that are not feeling very comfortable to open up. Maybe in Brazil that's not common, but here in the US there's a lot of religions that are considered minority, and not having culture connection, same background, it could be a difficult thing. Maybe you have some experiences that you can share on these, maybe with some of the minority religions in the country, in Brazil. the importance of this alternative figure that you mentioned in the patient's religion, especially when we're talking about the minority religions that sometimes it's hard to connect because of cultural issues and background.
Okay, first, many patients are very sensitive or very careful in sharing their religious and spiritual experience because something very dear to them. So they don't want to share such an important aspect of their lives with someone that they are not sure if this someone will truly appreciate or respect their experience. So the first point is to show to the patient that we are open and to this experiences, that will honor this experience, to tell the patient, okay, I'd like to know more about your experience. I'd like to let you know that you may feel comfortable because I respect of it's another very important aspect. All we are telling here does not imply that the professional must have some religion and spirituality. No, this can be all this approach can be implemented by a professional who himself has no religious background or spiritual tradition or whatever. Okay, it's very important. But anyway, we must be respectful. So to tell the patient that we are respectful to their beliefs and experience, that we will not pathologize just because it's not usual. This is important. We have worked hard on this in psychiatry, for example, in helping professionals to make the differential diagnosis or between health spiritual experience that may resemble a mental disorder from a true mental disorder that have some spiritual content, for example. This is very important. For example, at the annual meeting of the American Psychiatric Association this May, the end of this May, I will be there in San Francisco. We are leading a course in how to integrate religion and spirituality in clinical practice in psychiatry, and we will discuss exactly this, for example, about this distinction. How can we make this distinction and help psychiatrists to understand that not everyone who says that, or most of people who are saying they are hearing spirits, they do not have a psychotic disorder. Of course, some does, but most people do not have. So we must be able to make this distinction. And many patients are also quite afraid of share this experience because in the past they may have had some negative experience with health professionals. For example, I have several patients, for example, when they start to talk about their very important religious beliefs to previous psychotherapists, for example, they received a very negative response, a very cold response, or even a dismissive interpretation. It's very important because sometimes professionals may have a very anti-spiritual perspective and provide answer or interpretations that actually disqualify the experience and things like that. So this is definitely very important.
And it further strengthens all these stigmas that we have, especially regarding, you touched on things that are very important, I think, especially for religions that involve, for example, spiritual conversations, or medium activities, for example, that sometimes has a lot of stigma on those things. And this was one of the questions here, and I think you touched on these already a lot. Those patients that are sometimes, they don't want to open up and share their experiences, because if they say that they speak to angels or spirits, they're gonna be diagnosed with some sort of a mental disorder, when it could be sometimes, as you mentioned, but sometimes it's not. It's just that this person has a particular way of dealing with the spiritual realm that is a little bit different from the others. So we talked a lot about, in this last part, how to approach the patients, how to uh, uh, better connect with them so they feel more comfortable to open up as well. But in the last part of your response, you also touched on the healthcare provider side, which could be a little bit of a problem sometimes. And there is one question here in the chat: is how the patients, in your suggestion, could maybe approach the healthcare providers if they don't ask for anything regarding religion and spirituality. And I would guess here, especially here in the US, 99% of the times, nobody's going to ask you this. Maybe even maybe 100% of the times, no one is going to ask the patient if they believe in God, if they practice any religion, if spirituality is important for them or not. The approach is 100% clinical, pharmacological, or psychotherapy, with nothing else involved. So your suggestions now to patients, how to approach in the best way the healthcare provider actually to try to discuss this, because this is of course important for many people.
Yeah, I think the patient may tell the provider that this is an important part of my life. It has helped me to cope with this stressful situation, with this mental disorder, whatever. And if the professional should be sensitive to these cultural issues and spiritual issues, and if the patient analyzes that, quite often the professional will honor that and take it in consideration. But if the patient sees that the professional is not valuing it, there are two options. The patient can explore, of course, their own spirituality in their religious tradition, so on and so forth, and kept it apart from the medical treatment, or the patient may try to find another doctor that could be more open to these things. But I think nowadays it has become more acceptable in the medical community. Most schools of medicine in Brazil and in US have some teachings in spirituality. We are currently developing a curriculum for spirituality for psychiatry residents. We are doing this research in partnership with John Petit from Harvard University. We are developing a core curriculum of spirituality to integrate in psychiatry residences. So I think things are going better.
That's great to hear and reassuring as well. That's definitely very important, and it's going to be fundamental in the future to integrate these novel tools that a lot of people like you are creating, because we need to have that penetrance in the medical community. All right, so I think with this, that was the last question that we had here in the chat. I think with this, Alexander, thanks again, and thanks everyone who joined us tonight for the webinar. This was the third webinar of a series that is being put together by the US Spiritist Medical Association. The next is going to be scheduled for June. We're still working on the date, and soon we're going to release the date, the speaker and title, and that's going to be available in the website. So if you want to know more about this webinar series and the next scheduled talks, you can visit the website sma-us.org and go to events. You can also go to membership and become a member of the US Spiritist Medical Association. We always need more people to help us with webinars, to help us with other activities that we have, and also to contribute. So you're all welcome to be part of the SMA. So thanks again, and I hope you all have a good night.
Thank you. Bye-bye.
Thank you.